All right. Good afternoon, ladies and gentlemen. I'm Choun-Ki from Seoul, Korea. I'm working in the Seoul St. Mary Hospital. I'm a clinician and researcher. Today, I'm going to talking about the ring jack and the effect of ring jack on the stability of intraocular lens with hydrophilic and hydrophobic acrylic material. Okay, so we think about the general stress, okay? So, how can I move? All right. Yes, okay, I got it. So during the surgeries, we stress the journal very much. So even though the operator is very skillful, but there is a lot of stress in each procedure. During the capsulorhexis, it is also stressful to the journal. And during the hydrodissection or rotation of lens, there is a stress to the journal. So at the end of operation, we think surgery is very successful, but postoperatively, there is a lot of stress on the journal. So postoperatively, we can find some displacement in intraocular lens. Although the visual acuity is 20/20 at the end of operation. So especially in divided and conquered process, there is many stress to the journals, right? So many surgeons want to reduce the journal stress. So today we are thinking about the method, how can we reduce the journal stress, okay? In this case, the intraocular lens has had the stress to the journal depending on the site of the haptic tip. So the ideal intraocular lens is 360 degrees haptic, and this is a very ideal intraocular lens. But it is very difficult to insert this kind of IOL in the back through the small incisions. So we know the ideal IOL is optic plus 360 degrees haptic, but it is just theoretically ideal. So we cannot insert this IOL in through the small incision. Many surgeons tried to implant the capsular tangent ring plus intraocular lens. So this capsular tangent ring evenly stressed to the journal. Okay, this is a 360 degrees. But it is very difficult to insert the capsular tangent ring through the 3 millimeter incisions mechanically. And this slide shows the one report presented by me. So we published these articles in 2002. So we check the effect of capsular tangent ring on the IOL stability. So in table 3, so when you compare the tilting effect, the effect of capsular tangent ring on the IOL tilt, this is a capsular CTL plus IOL, and this is IOL only. So when you check the IOL tilt, there is a statistically significant difference between two groups. So in this result, we could say the capsular tangent ring reduced the tilting of the intraocular lens. So there is advantage of a capsular tangent ring, like preservation of a morphology of the capsular bag and the stabilization of IOL. So there is some surgical indication of a capsular tangent ring implantation is in case of general dialysis and in case of lens subluxation as well as high myopes. This is another article presented by Dr. Alio, and he checked the effect of a capsular tangent ring on the stability of a multifocal IOL. As you may know, for the multifocal IOL, high delicate surgery is needed. And in this paper, Dr. Alio emphasized there is a lot of capsular tangent rings has a good effect on the multifocal IOLs, like reduced intraocular aberration and increased MTF values and the study ratio, as well as regarding the defocus curve, that there is a significantly better visual acuity for the intermediate vision. So he emphasized capsular tangent ring is a very benefit on the combination of the multifocal IOL implantation. This is a slide for the pseudophakic accommodation. It is a UBM, and this is a scan. When after implanted the intraocular lens in the back, there is a movement of the intraocular lens and the forward and the backward. So also there, when you treated the pilocarpine on the eye, there is some change of the anterior chamber depth, and also there is movement of intraocular lens after IOL implantation. This means the centration of IOL is very important to improve the visual acuity. So, and there is some relative factors for the capsular contraction. So, especially in Asian eye, there is a lot of contraction of CCC after operation. So, there is several relative factors like jonular weakness and the sumo CCC. And also, in intraocular lens, there is materials and the shape of the intraocular lens can have an effect on the capsular contraction in the CCC. So we should know hydrophilic is better or hydrophobic is better. So we don't know. And what kind of shape is good for the CCC contraction? We don't know. So maybe plate or C loop. So in my study, we started to evaluate the effect of a ring jack implantation on the stability of a intraocular lens. So we used the two kinds of intraocular lens. Oops. And one is EC1 PAL. It is hydrophobic and one-piece IOL. And the other is Aspina 509M. It is a hydrophilic plated type of acrylic lens. So optic size is the same, and the total diameter is 13 in EC1 PAL, and in this case is 11. And the haptic angulation is 5 degrees and 0 degrees. And the incident size, recommended incident size is 2.2 millimeters and is 1.5 millimeters for this IOL. This is patient characteristics, and the group 1 and the group 2. We made two groups, and group 1 is a hydrophobic acrylic lens plus capsular tangent ring, and group 2 is a hydrophilic IOLs plus capsular tangent ring. The age, sex, and the preoperative uncorrected visual acuity is almost the same. The group 1 is 22 eyes, group 2 is 20 eyes. And we check the uncorrected visual acuity and the corrected visual acuity, and the decentration of intraocular lens, and the tilting of IOLs, as well as the size of capsular contraction. Okay, so we check the tilting of the IOL or displacement IOL using a shine plug image. So with the shine plug image, you can see the anterior surface and posterior surface of the IOL. Okay, this is the result. So when you check the decentration of IOL, so this is group 1 is, as I told you, it is a hydrophobic IOLs plus capsular tangent ring. And group 2 is a hydrophilic IOLs plus capsular tangent ring. So when you check the IOL decentration at postoperative 1 week, the hydrophobic IOLs shows much IOL decentration. This means hydrophobic acrylic lens is some unstable at early postoperative period, and then 1 month, 2 months, there is a decrease of decentration of the IOL. So in early postoperative period, there is some chance of decentration of IOL in hydrophobic IOLs. And then we check the IOL tilting. It is, as I told you, hydrophobic and hydrophilic. Hydrophobic shows much increase of IOL tilting in postoperative 1 week, 1 month, and 2 months. This means in hydrophobic IOLs, there is some chance, increase of chance of IOL tilting. So that makes some problem. And when you check the volume of the hydrophilic and the hydrophobic IOLs, there is a much different. Hydrophilic IOLs, volume of the hydrophilic IOLs is much bigger than in volume of hydrophobic IOLs. This is corrected visual acuity and the CC size. And this is group 1 and group 2, hydrophobic and hydrophilic. Uncorrected visual acuity and the corrected visual acuity is almost the same. But when you check the CCC size, we can make a more bigger CCC size in hydrophilic acrylic lens, because the size of optic is almost the same, but we can make some bigger CCC size. And then when you check the contraction of CCC at post-operative 2 months, there is a lot of contraction in hydrophobic IOLs compared with hydrophilic IOLs. There is almost 9.7 square millimeters, and the hydrophilic is just a 6.5. So there is a difference. So in conclusion, the IOLs implanted hydrophilic IOLs with a capsular tangent ring showed better IOL stability than hydrophobic and the capsular tangent ring at early period of the operation. And the CCC size is bigger, and the contraction size is less in the hydrophilic combination of hydrophilic IOL plus capsular tangent ring. The hydrophilic plate IOLs is more stable when implanted in combination of a capsular tangent ring. So I'm going to introduce the ring ZECT. So for a long time, I have used the capsular tangent ring. I developed the capsular tangent ring, but it is just, I can insert it capsular tangent ring manually, but it is very difficult. And Oftech developed the ring ZECT. There is two kinds of ring ZECT. One is inner diameter 12 millimeters, and the other is inner diameter is 13 millimeters. The material is PMMA, but it is very flexible. So it is some different from another PMMA. That is very flexible, and you can tie with this material. So, and then you can inject it this capsular tangent ring clockwise or counterclockwise. And the injection tip of the injector size is 1.6. So in minimal incisions, we can implant this ring ZECT in the back safely. And this is a characteristic of ring ZECT. It is preloaded, so you don't need to load. So it is already preloaded, and the self-loading and the single packaging. And it is very easy to handle, especially if the surgeons like one-hand technique, they can use, they inject this capsular tangent ring with one hand. And very controllable, and this is capsular circular expansion, and it makes a stabilization of the capsular bag, and safe IOL centration in the eye with the journal distance. It is less stressful to the journal, so it is very easy. And it can prevent IOL decentration after capsular shrinkage. They stabilize conditions during the phaco emulsification, and it can reduce the risk of the capsular fibrosis. And it can improve visual acuity when they implant along with the premium IOL. So especially when you implant the premium IOL, like multifocal or toric IOLs, it is very useful for them. And there is good indications for ring ZECT. So if there is a severe journalitis or in more complicated cases, and surgeons like one-hand technique, and we can use the ring ZECT to prevent prevent IOL dislocation. So when you implant the premium IOL, we should consider to use this ring ZECT. So I will show you my technique. As I told you, we implanted this ring ZECT through the 2.2 millimeters and the 3.0 millimeters. So, okay, I show you the technique. It's a ring ZECT and the preloaded, and you push, and then there's a capture and the back. So very smoothly, yes, right, and inject again. So it is my case. So in general, after removing all cataractous material, and then remove all things, and we injected this in the back safely. It is through the 2.2. So in case of 2.2 millimeters incision, we should insert this ring jack in the back with a 2-step. But when you use 3 millimeters incisions like this, and we can inject this ring jack one time. So not 2 steps, just 1 step like this. In the back, we can insert there. So there is less stressful to the journal. So as I told you, so in 2.2 millimeters micro incision, we can inject this ring jack in 2 steps. And the 3 millimeters incision, we can inject this ring jack in 1 step. And so I recommend you, and when you make 3.0 millimeters incisions, it's less stressful to journal. So if possible, I prefer the 3.0 millimeters incision when I use ring jack. Okay, thank you for attention, and if you have a question, and I will answer that.